guys, I am back with another wonderful video from Improving Birth Abbotsford today we're going to be talking about why induction matters from our wonderful book Why Induction Matters by Dr. Rachel Reed. She runs a wonderful blog called Midwife Thinking. It's great. If you love sciencey stuff, it's even better. It has information on all sorts of complications and variations of pregnancy and birth and labor. And it's just a fantastic blog, guys. I reference it quite a lot in some of my posts that come up. But I encourage you guys to go check it out yourselves rather than just checking on one link or two links. I've fallen down the rabbit hole many times in her blog, just reading for hours. I would read all day if I could. But she wrote this wonderful book, Why Induction Matters. And today we're going to be talking about making decisions on induction. Now, if you're watching, I'm hoping that you're also going to pass this on to any mom who may need it, especially at this time of year when induction levels rise. And remember, Abbotsford has the highest rate of induction in all of BC. So it's probably best that as many people as you can see this video. So share, share, share. I don't care about likes or anything. I just want you guys to get this message out. I'm not trying to make money off of this. I make no money off of this. This is just sending the message out. Every woman deserves to know that she has rights and decision making is entirely up to her. And a lot of the time when I hear of women that were induced, they say, well, I didn't think I had a choice. Well, I'm here to say you do have a choice. And the laws of informed consent are quite clear that legally, care providers are supposed to provide all the evidence, the risks, and the benefits, and the alternatives of any procedure. And this includes not just birth, but everything. And it is up to you to decide what you want to do. And if you say, no, I don't want to do that, and they say, well, you know, this could happen, you can still say no. You can decide, even if it was based on an astrology. If you say, well, my sign says that I shouldn't do this because my horoscope said this, you don't have to say anything about why you don't want to induce. It could be as simple as I'm scared of needles. That was my reason why I didn't want to induce, and I'm pretty glad that I said no, because it turns out that my son was fine, and being induced could have caused me to get a C-section, which I really didn't want. But it comes down to this. You are the decision maker. Your care provider, as it says in here, it says, it is the role of the healthcare professionals to share relevant information with women to assist them in making decisions about their options in maternity care. Now, they say the National Institute of Health and Care Excellence, that's the NICE organization in the UK, but we have similar guidelines here in Canada. So this is basically the same information. It says, provides guidance for health professionals about what information they should share with women when offering induction. They need to tell you the reason why it's being offered. They need to tell you where, when, and how the induction is going to be carried out. They need to tell you the arrangements for support and pain relief, recognizing that induced labor is likely to be more painful. They need to tell you the alternative options if you choose not to induce. I want to know in the comments, if you can, if you've been induced, I want to know if you were told that there were alternatives to being induced and what they were. I want to know specifically about Fraser Health, but I would love to know from all over Canada too, because I could help millions of people if I can get this information. The more people speak out, the more we can change things. So back to the book. Your doctor or midwife or obstetrician basically needs to tell you the risks and benefits of induction of labor in specific circumstances and the risks and benefits of proposed induction methods. So basically they need to go by the circumstances of what the risk is. If they say, okay, well, you're a first-time mom and we're going to induce you before 42 weeks and you have a 50% chance of having a C-section, they need to tell you that. And if they say, okay, well, you're a second-time mom, you've already had quite a few vaginal births before, and they use the term primiparous for women that have never had a live vaginal birth before, and then multiparous for women that have had children before. If you look at the Perinatal Services BC stats, you'll see those words up there, and it's under parity, and that's basically what it means. It's like first-time moms versus moms that have already had children. So if you're a mom that already had children and then they say, okay, well, you can be induced for this complication that's coming up, you may not have the same risk of C-section as a mom who has never had a vaginal birth before. Now, if you've had a C-section before, then the induction rate is basically the same as if you were a first-time mom. And having the C-section also probably would increase your chances of having another emergency cesarean if you were induced. So again, it comes down to your specific circumstances. There's also something called a Bishop score. I've posted that before. It's basically about dilation and effacement of your cervix and the station of the baby's head. I can repost that if you want me to. I can also just direct you to use Google, type in Bishop score, and it pops right up onto the screen for you. So that would be even faster and easier. And it just tells you basically where you are. If you're below a 6 for a Bishop score, you're more likely that baby's not ready to come and you could end up in a cesarean. So then there's the thing they need to tell you that induction may not be successful and what the options would be after that if the induction is not successful. If they're not telling you that the induction may fail, they're not doing their job for full informed consent. So sound off in the comments and let me know if what exactly is being said, because I have never been induced. I didn't go with an obstetrician, I went with a midwife, and I already went in knowing that I did not want to be induced and that I was not going to listen to anything about that unless there was an actual complication. I also only went to 41 weeks. So when I was told at my 40 weeks and 4 days that they would talk about induction the next week, I already knew that I was going to decline. So it didn't really apply to me. I want to know what your experiences are, because I want to know what's being said. I'm not having any more babies. At least I don't think I'm going to be having any more babies. So in addition to the health professional offering induction of labor, they should allow you time to discuss the information with your partner or friend or family member or whoever you're close to, your doula even, before coming to a decision. If they aren't giving you time to decide and they're just saying, okay, we're going to schedule your induction for next week without letting you have time to decide it, that's not informed consent. They should be encouraging you to look at a variety of sources of information. If they are only handing you their sheet on induction and not encouraging you to look at any other forms of information, including this video and definitely including this book, that's not informed consent. They are supposed to invite you to ask questions and encourage you to think about your options. So again, they need to give you time and they need to let you think about it and they need to let you ask questions. If they're not letting you ask questions and they're just saying, well, this is just what we do at this time, that's not informed consent, guys. They are supposed to support you in whatever decision you make, even if you make the choice that they don't want you to make. If they are not supporting your decision, you have the right to say, I want a different care provider. And you can say that even in labor. You can come into the hospital, be all set for your induction and say, you know what? I changed my mind. I don't really want to do this. And my waters haven't broken yet. And I just don't want to do this. And you can walk out. It's up to you. It's if they are not telling you that that is your option, that is your choice, that's not informed consent. So it says here, the information given must be evidence-based, clearly presented, so you need to be able to understand it. If you don't understand it, if they're just saying a bunch of percentages or saying, oh, the rate doubles after this, but they're not giving you the numbers, that's not informed consent. Remember in the last video I said that the risk of stillbirth was 1 per 1,000 going to 3 per 1,000 after 42 weeks and beyond for pregnancy? A lot of care providers may not use that term. They may not give you those numbers. It is your right to say, well, I know you said the risk doubles, but what is the actual number? I want to know the number. And they need to provide you that information. If they don't provide you that information, that's not informed consent, guys. So it says they are supposed to include quantifiable numbers, like I just said, rather than blanket statements. So basically what I just said is what's in this book here. They said it's not adequate to simply state that the risk of complication is increased or higher if labor is not induced. Instead, you must be told how much the risk increases in comparison to waiting for spontaneous labor. So again, basically what I just said is what's in this book. It's written down. It says it's the responsibility of the health professionals to ensure that they meet professional and legal standards relating to information sharing. If they do this, the decision and the outcome of the decision become the responsibility of the woman. They say woman, but it's birthing person. I mean, if we've got trans people watching, it's the same thing. If you have a uterus and you're able to birth a baby, it's still your decision. They say woman, but I'm going to be inclusive here. It says, failing to provide adequate information or coercing you into making a decision is a breach of professional and legal standards. That's the same here in Canada, okay? It's the same. This may be a UK book, but it says in these circumstances, the health professional becomes accountable for the decision and the outcome related to the decision. So if something goes wrong in this induction that you've been coerced into, because you weren't given all the information, it's on them. It is. You can file a complaint. I encourage everybody who has been wronged by the healthcare system, especially in maternity care, to file a complaint. If we don't complain, nothing changes because it just goes by the status quo. They're just looking at the numbers, guys. And if they think, well, everybody's happy, so it's okay, then nothing is going to change. We need to have our voices heard. And in the age of social media, it is very easy for us to have our voices heard. There is no excuse. I just sent a letter to Fraser Health letting them know that their induction rates were unacceptable for our population and that it is costing our healthcare system money and that money could be spent on the CT scanners that our hospitals desperately need. Because I got the letter. I don't know if you guys got the letter too, but I got the letter saying that our hospitals need money. And I took a look at those numbers. I'm like, well, wait a minute. If we just reduce the number of unnecessary cesareans caused by the inductions, we would have that money. So again, let people know. Let the hospitals know. Let the health boards know. Let your MLA know. Let your premier know. You can even send it to Justin Trudeau if you want. Send it to the Minister of Health. For BC, send it to the Ministry of Health for all of Canada. Let them know that this is going on and that this is no longer acceptable. Because here's the other thing. They're talking about research as evidence. It says maternity services claim to be evidence-based, and this term is usually used to refer to research rather than the other forms of evidence such as experience or intuition. Says that routine interventions such as induction were introduced as part of the general medicalization of childbirth, and it became established as a norm in hospitals. So these practices continue today, until there's good quality research evidence to support change. So that basically means that hospital policies on maternity care and hospital practices in maternity care may not be based on current evidence findings. It can take up to 17 years for evidence to come to light saying, hey, this isn't needed. We don't need this intervention. We don't need these policies in place anymore, such as moms not being able to eat and drink in labor. That was not evidence-based. That was based on fear. That was based on the idea that moms might aspirate if they had to get put under. But it's an outdated practice. Or the routine episiotomies that used to happen back in the 80s. Suddenly, 20 years later, we're not doing those anymore as routine. But at one time, all women were cut. Go ask your mother. Go ask your grandmother what happened. My grandmother probably had forceps and an episiotomy for no other reason than that's just what they did. So it comes down to evidence. Researched evidence may not always be implemented in hospitals until it's pointed out enough times that there's reason for it to change. And if women aren't complaining about it, there's no reason for them to change because everybody's happy. Nobody's complaining, nobody's suing, nobody's saying this is wrong. We need to get our voices out there. Dads weren't allowed in the delivery rooms until women started saying, hey, I want my husband in the delivery room. So the other problem with just using research is that undertaking good quality research is difficult because it requires funding. Now, funding is usually brought into place for medical technology and pharmaceutical companies, and it's usually put for cancer research and for drugs. It's not really going to maternity care. So a lot of the research funding that's being done is not, it's just not interesting, I guess, to them. They don't really care because they have other things that they're doing. They're worrying about cancer research and they're funding everything else. So when there's evidence available, there's this thing called a Cochrane review, and that's taking all of the studies that have been actually done on maternity care on specific issues, and they condense them, and they look at how it was conducted and where the holes are in the evidence that's being presented. And sometimes the review tells you that these studies that were done are not evidence-based and that the sample size was too small or it was too biased. If you've ever taken a university research course, which I actually have, I even took a psychology class and learned about how studies need to be done and conducted, you'll know that you need an unbiased sample size. You need to be able to replicate the evidence, which means reproduce it. And if you can't reproduce that, then it's not a valid study. So then there's this whole thing about evaluating risk. Now, I talked a little bit about that in the last video. We are running a little high here. So I'm going to have to make this a two-parter because we're almost at 20 minutes. But for evaluating risk is basically what's the individual risk to you versus what's the risk in the statistics. So if they say, oh, well, there's a chance of stillbirth. Well, if the risk is, again, 1 per 1,000, and you don't think that that's a very high risk versus the risk of having a cesarean, then that risk isn't really relevant to you in looking at the evidence on whether or not you should be induced. However, if you're a mom who has had several miscarriages and this is your baby, your rainbow baby, and you really don't want to take that chance, then maybe induction might be something that you would consider, because that 1 in 1,000 chance of this stillbirth is scary to you, and you just don't want to take that chance. And you don't care how your baby gets in the world, you just want to hold your baby in your arms, and that is perfectly fine. And if the risk of having a needle, I mean, I personally am terrified of needles. That's why I had vaginal physiological births. It's because I did not want the needles. So for me, being told that my son was small for dates at 35 weeks, I was more looking at as, well, I want to make sure he's still growing. So I asked about the placenta functioning, and if I wasn't terrified of needles and wasn't terrified of having a cesarean and had really, really not cared how my birth was, then I probably would have said, okay, well, I'll consider induction. But I really didn't want that. So that risk factor for me of having the cesarean and having an IV and everything, that was a high risk for me. That was not something I really wanted. So I looked at the evidence a little bit more closely and monitored my pregnancy, and I decided to go for additional monitoring. It turned out that my son just needed the extra week. He just needed to be born at 41 weeks instead of 40 weeks. And he came out 7 pounds, 13 ounces. So he wasn't really small for dates. He was just small for dates that specific time. And then he just shot up and grew, and I have all the stretch marks at 39 that I got at 39 weeks to prove that he just shot up in growth at 39 weeks and beyond. But it comes, like I said, it comes down to your risk. The doctors and hospitals and your care providers are going by risk of what it says in the evidence. But they are not you. They do not take into account any risk factors that may be psychological. They don't take into consideration the long-term effects. They're looking short-term. Because once you're out of the hospital, it's not on them anymore. It's not their jurisdiction. They can't tell that there's going to be problems in the future for you, psychologically or physically, for the type of birth that you had, for being induced or even ending up in an emergency cesarean, because they're not your care provider anymore. Your family doctor is, or the general practitioner that you see at the walk-in clinic. They're taking care of you. You may see another obstetrician with a midwife for a second pregnancy, and the first doctor doesn't see you anymore. The hospital may be different. You may be in a different region. The risk factor just isn't there for them. But you will have this birth as a memory for the rest of your life. And that's where you have to look at not just the studies that have been done and the risk relative in the population and the risk that it says on the piece of paper, but also what's the risk to you? What is the risk to you to be induced versus what is the risk to you if you wait, or if you just question it a little more, or if you choose an alternative option? What's the risk to you? What's the individual risk? What's the social risk? What's the risk to your physical and psychological well-being is what it comes down to. And I will touch more on that in the next video. But for now, I have to go because it's 23 minutes and we've run out of time. So I will see you next time. Take care. Send this to as many moms that may be expecting in December and January, because they're going to need it. All right. Have a good night. Bye, guys.